MIT is a type of speech-language therapy that uses rhythm and melody to assist in speech production and recovery. It is used with individuals who are characterized with non-fluent aphasias, like Broca's, for example. The name of my treatment study is The Effects of Modified Melodic Intonation Therapy on Non-Fluent Aphasia, a Pilot Study by Betho and colleagues. This study was published in October 2012. The treatment type was Modified Melodic Intonation Therapy, and the design was a randomized controlled single-blind study. The treatment was designed for acute stroke survivors with non-fluent aphasias, specifically Broca's aphasia. During the treatment study, there were a pre and a post-assessment done on the treatment and the control groups. After the pre-assessment was completed, the participants were put into a treatment group for 10 to 15-minute music therapy sessions with a board-certified music therapist trained in MMIT. In the first session, the music therapist used the first phrase from the pre-assessment repetition section, "I need a drink of water." The music therapist told the phrase to the participant in a normal speaking voice and tone when giving the instructions for the activity. The participant only heard the phrase spoken one time during the session. After that, the phrase was sung to the participant. During the first session, the music therapist only sang the phrase and modeled it for the participant. When the participant sang the phrase, the music therapist used hand-over-hand modeling to have the participant tap along to the rhythm of the phrase. After the completion of the session, the music therapist determined if the participant needed to come back for more sessions. The treatment stimuli that was used during each session was adapted from the WAB. These statements included, "I need a drink of water," "Hello, my name is," and "I have to go to the bathroom." The protocol allocated for 5 sessions, but only 3 sessions were performed. In total, there were 30 participants, 14 in the control group and 16 in the treatment group. There were 3 sessions, and each consisted of 10 to 15 minutes. The first session was the only one in which all 30 participants participated. Overall, the participants benefited from MMIT, and the results show the positive effects of using rhythm and melody to assist in speech production. This chart shows the comparison between the control group and the treatment group in their pre-visit 1 scores and their pre-visit 2 scores. Even though participation was low after the first session, the scores shown in the chart indicate positive outcomes of MMIT in acute settings and people exhibiting non-fluent aphasias, specifically Broca's. In Visit 1 pre versus Visit 2 pre scores, a positive correlation in MMIT is compared to the control group.
The title of my article is The Efficacy and Timing of Melodic Intonation Therapy in Subacute Aphasia. The authors include Van de Meulen and his colleagues. The year of publication is 2014. The design is a baseline multi-center randomized controlled trial, and the treatment was designed for individuals ages 18 to 80 who speak Dutch with subacute severe non-affluent aphasia, persisting until 2 to 3 months post-stroke. Therapy was done for 5 hours per week for 6 weeks. The assessment was done at baseline T1, then after the first intervention period where the efficacy was evaluated T2, and then after the second intervention period T3. The participants were split into 2 groups listed. Melodic intonation therapy group, there were 16 people, and then the control group, which consisted of 11 people. The control group did not focus on spoken output like MIT, but rather focus on linguistic modalities such as writing, language, nonverbal communication strategies, and comprehension. The MIT group focused on hand tapping the rhythm while singing short utterances together. As time went on, support from the SLT decreased and the singing became speaking. The utterances produced increased complexity as the time went on. The first set of utterances were picked based off the participants' frequent use in daily life communication. For example, an utterance was, "Coffee, please." Later on, the utterances became less frequent in daily life, longer, and more complex. In conclusion, these patients with subacute severe non-fluent aphasia benefit from MIT treatment. All the results favor the experimental MIT group for all of the measures, and earlier treatment may lead to a greater improvement.
We chose to use the article that I completed my research project on. We are altering this treatment to apply to people with transcortical motor aphasia using functional phrases that would typically be used in a subacute and/or acute hospital setting.
Our goal is the client will utilize a functional phrase with melodic and rhythmic hand tapping with 80% accuracy with maximum tactile and verbal cueing. We are using a functional phrase like, "I would like coffee." This is our therapy example. An ideal session is 10 to 15 minutes long.
Today, I will be the clinician.
And I'm the client with transcortical motor aphasia.
Today, the instructions are going to be spoken to the client and then sang in melody. So today, we are going to use a functional phrase that you have used every day. I would like coffee. And then after that, I'm going to sing. And then you will follow and you will repeat what I say. This is trial 1. I would like coffee. This is trial 2. I would like coffee. This is trial 3. I would like coffee.
Data is usually gradual over many sessions since this is used for people with severe impairments. It can be translated outside the hospital setting and incorporated into patient facilities, specifically outpatient. In conclusion, MIT is effective for patients with non-fluent aphasia, and both of our articles show the positive effects of using rhythm and melody to assist in the speech production.